Thank you very much to everyone, and it's a pleasure to moderate this MDT. And please be participative in each presentation. We have prepared 3 cases, and that for sure will be of added value for every one of us. So let's start with the first case. Will be presented by Francis Lim.
Good morning, good afternoon, good evening. We are all from all over the world, and this is really not for only orthopedic surgeons, for everyone. My talk is about just metastatic cancers to bone, not really sarcoma, but as you know, we have more patients with metastatic bone cancers. So let me present 2 cases. My first patient is 59-year-old male with a liver cancer with a severe pain, and he's undergoing lots of new treatments. These days, oncologists are changing drug every few months because there is a drug resistance. Then they change drugs. The second patient is a 54-year-old woman with a newly diagnosed breast cancer, and because of this massive bone defect, she cannot really receive ambulatory anti-cancer drug therapies. So orthopedic surgeons only talks about biomechanics, but many of you are oncologists. Cancers are radio-resistant, radiation maxed out, drug-resistant, local cancer growth. Bone biologists talk about bone cancer interactions, bone biology, rank ligand, cytokines. From patient perspective, they don't want to spend 2 weeks, 4 weeks, even 3 months to recover from our heroic orthopedic procedures. So if we have a patient like this, how would you treat this? If we ask arthroplasty surgeons, they will use this. Trauma surgeons will use more plate and screws. Sarcoma surgeons use more mega prosthesis. But I want to change the philosophy a little bit, just to provide oncologists and patients for new drug therapies without any delay. So my procedure is called AORIF, ablation, cement, zoledronate, and internal fixation to address local cancer control, biomechanics, local cancer biology, and life. So this is what has been done in the past. For triple aortic aneurysm, they used to do open surgery. For mitral valve replacement, they used to do open surgery, but they are now doing all percutaneous procedure. So at least for orthopedic procedures for cancer patients with metastasis, why not percutaneous treatment? This bone defect is very small, only quarter size, and why we have to make 50 centimeter long incision and the big implants, it really doesn't make any sense. So my talk is about minimally invasive procedure. And since I'm a surgeon, I'll briefly introduce techniques. So patient has lots of big defects, truncal obesity, and many orthopedic surgeons in my country still do big reconstruction, making long incision from to here, but I'm using very small opening in the skin and do minimally invasive procedure using cannulate screws. And the guide wire placement is actually very simple. If you have this hairpin loop view, you can place guide wire through the anterior iliac crest or posterior iliac crest. Then you can insert cannulate screws as a portal. So this is the guide wire. I'm placing a guide wire in the OR. Again, hairpin loop here, inner cortex, outer cortex. As long as you stay between these 2 lines, you're home safe. This will directly go to the supraacetabular region. I advance the guide wire. Then advance the cannulate screws of the guide wire. Then I retrieve the guide wire. I usually use 2 because we can ventilate and also we can prevent a rotation. And guide wire placement is confirmed on the iliac crest view and inlet view. Then I kill cancer after biopsy. Why I kill cancer? Let's look at this. 1 ml of cancer contains 100 million cancer cells. These days, I do not feel comfortable in spreading cancer during reaming or doing some internal fixation, because medical oncologists would like to kill even 100,000 cancer cells with the new drugs. So this is my new philosophy, very strong. And I do ablation for instant local cancer control. And also we can liquefy tumor matrix. All the osteal lesions are not empty. There can be fibrous matrix, sometimes bone matrix as well. So you can use your ablation of your choice. I usually use
the lesion is really cystic.
radiofrequency ablation because cryosurgery can cause avascular necrosis of the femoral head. If I inject the dye can leak out anywhere. That means if I inject the bone cement, cement can leak out anywhere. And this is why I do balloon osteoplasty, meaning I use a kyphoplasty balloon so that I can open up the space, control bleeding, prevent cement or tumor embolization. Then I inject the cement, high viscosity cement to prevent embolism. And I cement, I do cementation under intermittent fluoroscopic guidance. This is really very, very simple procedure that really changed my practice over the past 7 years. Then I advance the screws all the way in. And this is the post ARIF procedure. And again, I'm very proud. I killed the cancer cells. Then I did internal fixation. And this is the dressing. And this is actually anesthesia record showing this kind of a procedure takes only 1 hour. And this is the patient 2 weeks later in the office. Patient lived 1 year and no additional procedure was required.
Yeah.
And this is the lady I showed you, newly diagnosed breast cancer. I cannot waste 3 months for recovery after megaprosthesis surgery. So we did a very simple procedure. And since there was a bone destruction at the superior pubic and acetabular junction, I did also additional iliopubic screws after cancer ablation, intraop X-rays and post-op CT scan. Patient is still alive at 2 months after successful breast cancer chemotherapy. Her function is outstanding. She's still developing a lot of other skeletal metastases, but left pelvis is very well preserved. And this kind of a procedure is minimal and therefore very powerful. We can do multiple procedures. This is the case of a bilateral acetabulum and femoral neck lesions with a left femoral neck fracture, lung cancer. She's so thin, she cannot undergo 2 total arthroplasty. It's impossible. She did very well by doing all percutaneous procedure in bilateral acetabulum and the femoral neck. And the PET scan shows actually very excellent local cancer control. And I can really assist the medical oncologist for advanced oncology care. We can combine with the spine procedures. We can combine with the sacroiliac joints. Even we can do AORIF in renal cell cancer patients by doing angiogram through the contralateral femoral artery. Very interestingly, ARIF does not increase any bleeding because of the bone cement, balloon dilatation, and the cancer ablation. So now let me talk about biology because we have a pathologist on the panel. Cancer cells cause inflammation in bone, thereby activating osteoclastogenesis and also inhibiting osteoblastic bone formation. And I recently published that cancer cells are transplantable. That causes massive inflammation. That means if surgeons do reaming for the femoral nailing or acetabular reaming, we can spread the cancer cells very easily. And this is, I think, a kind of a scientific crime. And likewise, presence of cancer cells inhibit fracture healing. So this is a normal bone homeostasis diagram. Osteocytes are very important regulator of bone formation by forming sclerostin to inhibit osteoblastic bone formation. And also they produce rank ligand MCSF. We are giving bisphosphonate but it does not work. Why? Cancer cells produce sclerostin, and they also stimulate all the cells to produce cytokines to increase osteoclastic bone resorption and inhibit osteoblastic bone formation. Therefore, we have to kill radio-resistant or chemo-resistant cancer cells. And this is how the ablation works. It's a slow heat convection, but you can use a microwave or even cryo if the lesion is away from the acetabulum. And ablation is not just mechanical. Actually, ablation enhances a targeted therapy such as a VEGF inhibitor. This is a radiofrequency alone, radiofrequency with a VEGF inhibitor, and we can see increased necrosis in liver cancer. And these days, immunotherapy is very important, checkpoint inhibitors. When we kill cancer with a radiofrequency ablation or thermal necrosis from bone cement, we expose tumor antigens from partially dying cancer cells, and we can enhance checkpoint inhibitor efficacy. I think this is really important. And also, checkpoint inhibitor itself inhibits osteoclastogenesis, and it can increase bone formation as well. And ablation itself is known to have safe for bone homeostasis. And after ablation, circulating cancer cells and the cytokines decrease in the blood. So I think combining ablation and minimally invasive orthopedic procedure really makes sense in patients with massive metastatic bone disease. Now we'll talk about biomechanics because we have orthopedic surgeons on the panel. I'm not doing bypassing or bicortical fixation. I'm just using simple buttressing internal fixation technique along with the bone cement because we are going from the iliac crest that is the strongest, longest path, bicortical, actually tricortical, and that provides a very stable internal fixation, just like an ice cream cone implant. I'm using 2 screws to prevent rotation and also to prevent cement embolization. And I did some biomechanical study, and just having 2 screws and the cement really prevents crack near the acetabulum. Let me give you a clinical update in the last 2 minutes. So this is a clinical outcome. There are no functional criteria for patients with acetabular metastasis. So I devised from 1 to 10. 10 is normal ambulation without pain. 1 is bed rest with extreme pain. These are my cohorts of 72 patients. A lot of patients are either bedridden or barely walking with a walker or a wheelchair. And within 2 weeks, they can show dramatic increase in pain score and combined ambulatory score. And this is well maintained beyond 1 year without additional total liver hemiarthroplasty. What about survival? This is very interesting. This is a path fracture predicted survival. And this is my cohorts. Somehow all the patients live longer because they can get chemo or new drug therapies next day. And also we can decrease cancer burden in the acetabulum. And lastly, the bone mass change is dramatic. If I have this patient today, I may use a megaprosthesis with a sacral fixation or even inoperable. But look at this, 3 days later, 2 months later, 11 months later, and 1 year later, there's a dramatic increase in bone mass because we are changing local bone cancer interactions by killing cancers. And again, those patients who show increased bone mass can live longer. Complications, almost none. No infection, no hardware failure. Only 1 patient underwent hemiarthroplasty due to flattened head due to initial acetabular collapse. But with this femoral head, still patient can do a lot of different things. So in summary, I apologize, I did not follow Sarcoma Academy protocol, but all those 2 patients are doing very well. In my opinion, I think ARIF should be the safe, effective first-line treatment before orthopedic surgeons consider megaprosthesis or big reconstruction. And I'll stop here. And thank you so much for this wonderful opportunity.
Thank you, Dr. Lee. Impressive and convincing images and videos as well. So we are opening time for interactions for the audience and panelists as well. So in the meanwhile, I have a question for Dr. Lee. Is, for instance, in the context of metastatic setting where we are using TKI, for instance, with anti-angiogenic properties, how long should be stop anti-angiogenic drugs for making this procedure? I mean, for instance, sunitinib or sorafenib in the context of liver cancer, how long should be stop before this ablation and this ARIF procedure?
Dr. Martin, thanks so much for the question. Basically, this is a percutaneous procedure with a surgical incision, and therefore all patients continue all the medications, even including blood thinner. So, and also all the drug therapies can resume the next day, even radiation as well.
Okay.
Hey,
So,
Jay.
Jay?
Oh, hey, it's Jay Sorry, I'm only
Yes.
partially recognizable in the surgical mask. So Francis, congratulations, thanks. That's a great presentation. And I think at all the meetings, there's a lot more emphasis now on percutaneous fixation. So this is not for all metastatic disease. You can't use this for all long bone lesions, but it's certainly, you've shown a lot of good examples where minimal surgery can help patients in palliative situations. So I think it's it's adding to the body of literature that's very helpful. Not everybody I think who talks about this, a lot of people just use fixation in cement. Not everyone talks about radioablation or putting bisphosphonates in cement. I think the radioablation kind of makes a lot of sense, especially because one of the problems when we operate on these patients, as you noted, is that it's not a hole. So there's often solid tumor. And if you don't do something to the solid tumor, you actually can't inject cement in the hole and you can't do the procedure, or you can't get the benefit. So I think that's a really good addition to this. And so I guess a couple of questions would be, do you do this yourself, or is it like in the operating room, or is this in an interventional radiology suite? Do you do this with an interventional radiologist? The other, I guess, big question would be, what happens if there's cement extravasation, or have you really never seen that? Because there's a lot of times on the CT scans, we see where the cortex is deficient and there's a soft tissue mass, or does the cement always just stay contained within the tumor, the boundary of the tumor? I think those are sort of just some practical questions for people.
Oh, thank you so much for really asking an important question. Regarding the imaging or operating suite, I do in the regular OR these days because it's very hard to book a room in the cardiovascular Ziegler room. So
Sure.
That's why I devised this imaging technique. As long as you have this kind of iliac wing view and hairpin loop view that shows both anterior and posterior iliac crest, you can safely perform this procedure in the regular OR. And I published this paper in the ICL and all others, and you have access to that as well. And the other thing is about cement extravasation. As a matter of fact, a lot of patients even do not have any bone. So it's not kind of extravasation. It's a kind of really reconstituting defective acetabular bone roof. And it's very interesting. Even though cement may extravasate, I'm using very high viscosity cement that's used for vertebroplasty, and therefore they do not form any fragments. Even though they may extravasate, they actually form very nice neoacetabulum that articulates very well with the acetabulum. And surprisingly, not many patients complain of any pain. And I really have not performed any hemiarthroplasty except one patient. So I'm still learning, and I'm not saying this is the way to go, but all your questions are so valid and so insightful.
So do you do this with an interventional radiologist, or do you just do this yourself?
I usually do by myself if it's in the regular OR, but I do with the IR doctor because we developed the business plan together, and we
Right.
always exchange emails. If he's out of town, I'll do by myself, but
Right.
I'm always involved in either case. Yes.
Okay, thank you. It's a really great advance for a lot of patients who otherwise couldn't have big surgery, and you've obviously made really good inroads showing, good functional outcome. And as you've shown, like even seeing some of these patients with bone reconstitution and lack of tumor regrowth. Have you seen patients who have had this where there's been progressive tumor growth afterwards, or progressive bone destruction around your reconstruction and failure?
Yeah.
Or
Yes, I show the slide. All the patients actually improved bone mass around the ablation and the bone cement. And I forgot to mention, I mix zoledronate in bone cement, but even without zoledronate, it should really improve. The mixture is about 5% volume percent. That means 0.5 ml of zoledronate in 20 ml of bisphosphonate. If you don't mind, can I just show one slide? Is it possible still, or am I over time? Only one slide only. I apologize.
it's so interesting. I think everyone wants to see.
This is actually, I put endoscope, pediatric ureteroscope through the cannula screws. And this is the patient's pre-op lesion. Protrusio is not a contraindication. The reason is they need either chemotherapy or they may die within 30 days. And this is the cancer. I'm looking with the endoscope. And this is the acetabular cartilage. And there is no subchondral bone. And this is the femoral head. That means if I inject the bone cement, and this white powders are bone cement.
Because of the viscosity now, that's not going more viscous.
That's right.
And the cement actually forms the roof. And the patient was able to get out of bed,
You see it, great.
but did not live long enough. She passed away within 6 weeks. So in retrospect, I think my procedure still has some value. But of course, it's not everything.
Yeah, so you're basically showing that even when there's no bone, if the cartilage is intact, the cartilage will act as a barrier to cement. It's probably not much different than how people treat giant cell tumor of long bone, and many people use cement, and and a lot of people just put cement right on cartilage. And although there may be long-term implications for people who are young with giant cell tumor, for these people there's probably less implication. And even if this failed and they needed a bigger operation, you could do it. But if you could avoid a lot of these people a big operation, they're back on chemo faster, there's less pain, less intervention. It's a really good technique that's starting to change how I think a lot of people in orthopedic oncology approach these things. So congratulations to you. It's very interesting.
Your analogy on giant cell tumor is really so insightful. I'm learning from you. Thank you so much.
To get you to come to Toronto, show us so we can start doing that.
Great. Thank you very much. There is another question from the audience. Where do you see the limit of the procedure? For instance, acetabular fracture, intraarticular distribution of the bone metastasis, size of the lesion?
I'm not over ambitious, but I'm using this for actually focal femoral head and neck lesions instead of putting hemi or long nail. And also I'm doing this for sacroiliac, distal femur, proximal tibia, any periarticular lesions.
Okay. Yeah, I have a biological question, additional, Dr. Lee.
Yes.
Have you tested in some way if after the ablation are you achieving an immunogenic cell death in some way? I mean, there is a peculiar type of tumor cell death that is able to stimulate the immune adaptive response. So there are canonical biomarkers that can be measured. And I was wondering if you have checked these kind of biomarkers in this kind of procedure.
Thank you so much. This is a great question. I showed actually 1 or 2 studies by others. I have a lab as well, but I have not shown it. I have not measured any tumor antigens. I have not measured our PD-1 or CTLA. 28 or any others. But there are many literature by radiation oncologists and interventional radiologists showing that antigens are exposed by partially dead cells. And I did the pathology before and after ablation, and I expected massive necrosis right after ablation, but actually they are all morphologically intact, to my disappointment. And that's probably perhaps they preserve tumor antigens.
Okay, thank you. There's another question from Dr. Schelling. Can you explain us your thoughts about when to use RFA and when cryoablation?
Cryoablation is a really outstanding technique, and you can actually see ice ball. As you know, Hounsfield unit, water is 0, air is -1,000, brass is 4,000, ice is -100. You can see very nice ice ball. The problem is in the acetabulum, it's a circular distribution of cold necrosis, and it can cause thrombosis of the medial circumflex artery or obturator artery, thereby causing avascular necrosis. So around the acetabulum, I think ablation is safe, but other locations, I think cryo will be outstanding as well.
Okay, thank you. There are other questions from Dr. Nahafi. The first question is, in your experience, does normal bone come back after RFA of the lysis?
The answer is yes. The reason is, as I said, cancer inhibits osteoclastic bone formation, osteoblastic bone formation, and increases osteoclastic bone resorption. And by killing cancer, bone homeostasis is a kind of recovered. And plus, we also have a local bisphosphonate, zoledronate released from the bone cement. And as you see on the CAT scan, they are all normal bones.
Okay. And the second question from Arash and Hafi is in the case where there was barely bone in the iliac wing. Where did you anchor the screws?
Iliac crest. I don't know why. Most of the time, acetabulum is gone, but iliac crest is intact. I don't know the vascular supply. So this is actually, I'm attacking cancer through the normal bone, not from the defect directly. As an orthopedic surgeon, we always go through the defect, then you can lose the screw in the pelvic cavity. So always go through the normal bone. You can avoid the bleeding, tumor contamination, and you have a better anchorage as well.
Great. So any other question from the audience or panelists? Yeah, Andre?
Well, hi, good morning to all. I'd like to ask Dr. Francis and all the other panelists. Here in Brazil, we're starting to use microwave ablation. And I'd like to hear from you guys if you have an experience comparing radiofrequency with microwave or even cryo. Cryo here is much more expensive, for instance, than radiofrequency. I'd like you to comment on the cost and efficacy of the three techniques.
I have a only USA price. Radiofrequency ablation, I think the heat is very moderate, 65 degrees to 90 degrees. The cost is $4,000 for 2 probes. I think it's ridiculous. But bone cement is, as you know, $45. It generates heat about 93 degrees or 100 degrees. But as Dr. Jay Wanda said, sometimes defect is not empty. So there's a little issue. Cryoablation probe is very expensive, $2,000 for 1 probe, and 5 or 6 will be $10,000. So it's not really great. Microwave is fantastic. It generates about 300 degrees right away, instant. But if there's a dense matrix like a bone or collagen, there is no heat dissipation and the desiccation. So still, it's not perfect. But if your hospital does not provide any of 3 of those, I think even using bone cement alone with the zoledronate is beneficial, because zoledronate is off patent as of 2012. Denosumab is $285-100, heat unstable, but zoledronate is only $45.
Francis, can you not reuse the probes? Like, can you not use one probe and just use it in each different screw to try to save cost?
I do that in one patient. In theory, we can even, I mean, the company want to make money, so I feel bad. regarding that caused the issues.
But you can reuse the probe multiple times, right, in one case.
Of course, because 95 degrees, no cancer cells will survive around the probe.
How long is each probe when you put it in and turn on the RFA, how long does it have to stay?
So RFA usually takes 15 minutes for normal spine, but I do fast track, 9 minutes. They can generate heat much faster. Microwave is only 30 seconds or 1 minute. It's 300 degrees. Cryo takes longer.
I see. Okay.
Thomas has another question.
Mm.
Yeah, may I have a question, please?
Yes,
Of
please.
course.
Yeah, of course, we have to thank Professor for this interesting presentation because it's really changing our practice, especially for this, situation in patients with a bad situation. It really gives a good solution, especially for metastatic disease. But I still believe that we have to establish indications and contraindications. Of course, it's a very good technique, but we need indications and contraindications that for metastatic disease is really good. I'd like to say that I had a patient with metastatic hearing sarcoma, and during the ablation had acute desaturation, changes of the heart rate, all of that. It was a severe problem, but anyway, and this is my comment. I'd like to ask you, if you use two probes, you do it simultaneously or one and after the other one?
I usually use the simultaneous because the rate limiting step is really ablation time. As a surgeon, we cannot wait 15 minutes. It's ridiculous.
I clearly understand.
I do the double probe, and if sometimes I stop at 9 or 10 minutes.
Just together, okay.
But I don't think the technology is perfect. We do not have any in vivo analysis system. So I speculate, maybe all of us can work together. We may do everything now, probably endoscopic surgery. As you know, spine decompression is now done by combined probe that has a bar, RFA, suction, and endoscopy. The time should come in the next 5 years.
Okay, thank you. Thank you.
Great, Dr. Lee. Impressive presentation. Thank you very much. I think we have to move on the next presenter. And I would like to introduce you, also Alexandra Gronki will be in charge of the next moderation. And please, the next presenter can share the screen for the next case.
Thank you very much. May I proceed with my presentation?
Yes, of course.
Yes.
Thank you. Good evening, good morning, afternoon, depending upon which time zones and where you are in which part of the world. I'd like to thank Sarcoma Academy for the opportunity given to me to present this challenging case. And with this, I sort of built a theme of sharing with you, delving deeper into the world of the undifferentiated small round cell sarcomas. So I'm going to use this case as like a springboard to sort of delve deeper into this exciting and challenging area of the undifferentiated small round cell sarcomas. The case in question was a 62-year-old gentleman who had this slowly growing soft tissue mass over a 1-year duration and developed pain over a period of 7 days of late. So clinically, there was a firm soft tissue mass noted in the middle 1/3 of his leg, which was tender on the palpation. The overlying skin was stretched and essentially unremarkable. The ultrasound performed elsewhere showed the solid mass measuring 8.1 centimeters in the largest dimension. So the images that I had to myself, you can see a large soft tissue mass in the middle 1/3 of his leg, which is about 6 centimeters in size and mostly in the subcutaneous plane, sparing the underlying bone and the overlying skin being stretched, but essentially not ulcerated, or, clinically it was also not ulcerated. On the PET, the CT mass was heterogeneously enhancing. You can see in this photograph. So there was a biopsy that was undertaken for a diagnosis, and you can see here morphologically a very uniform, monotonous appearance of these small round cells. Actually, small to medium-sized, if we in pathology call these, because you have scant to moderate amount of cytoplasm in the individual tumor cells. So this was essentially like a morphology of a small round-celled tumor. Apart from the arrangement in the sheets, there were areas showing these cord-like arrangements. You can see these cells arranged in these cords, and also a little more thicker cords, which we call as tuberculate, in this very prominent sort of bluish to pink myxohyline stroma. So there was another pattern forming these tumor cells in more glandular or rather pseudoglandular pattern. So this gives an idea towards the pathologist. Maybe we're dealing with something which is epithelial, like a carcinoma, or maybe a soft tissue tumor which has epithelial appearance. So with these thoughts, we went out to a good friend, immunohistochemistry, and we started to do some stains to see or identify what this tumor could be. And it showed a positive expression of the epithelial membrane antigen, that is a epithelial marker. So with these thoughts I had in my mind, with this profile, I had some thoughts in my mind. Perhaps we're dealing, if it's a soft tissue mass, could it be a myoepithelial tumor or a myoepithelial carcinoma? The other differential came as, could it be an extracellular myxoid chondrosarcoma, or maybe an unusual round cell sarcoma that we're dealing with? So we did some additional stains. So, you can see this is keratin that was negative here. And if we have to substantiate the diagnosis of myoepithelial tumors, apart from epithelial marker, we need to have positive expression of either of these two, F1 or the GFAP. That is the criteria laid out by a nice paper by Dr. Fletcher and Dr. Joseph Hornick on myoepithelial tumors. So this kind of ruled out possibility of a myoepithelial tumor that was quite close. Then there's a new variant of Ewing sarcoma, which was epithelial differentiation, adamantinoma-like. So I did P40, and this was negative for the same. The other usual suspect became a sclerosing rhabdomyosarcoma. So Desmond negativity kind of ruled out that possibility. And then I went on to thinking about the unusual suspects, the recently described the BCOR rearranged tumors, for which we use BCOR immunohistochemistry. And the W1 for TIC or the chick rearranged tumors. It was also negative for NUT1, which comes in a small subset of the CF for the chick rearranged tumors. Now, despite being a round cell tumor, it was low in its proliferation. The MIB1 was, or Ki67 was low. And with this thought, I also did MIG2 and CD99, which stand up an essential criterion to substantiate your diagnosis of Ewing sarcoma as part of the recent WHO 5th edition 2022. And so despite being too positive, the morphology was not quite fitting into the possibility of a Ewing sarcoma. Maybe an adamantinoma like Ewing sarcoma was one close thought. So with this, I don't know how many pathologists we have across which part of the world with their practice, and I just sort of try to put on a poll question. I don't know if it's feasible. So how would in pathology one would proceed? Would you offer differential diagnosis of extracellular myxoid chondrosarcoma, myoepithelial tumors, hybrid sarcoma, or carcinomas? Would you stop with the diagnosis of round cell sarcoma because the therapies in round cell sarcoma at this point in time are same? They are treated mostly on the lines of Ewing sarcoma protocol, especially in this scenario of this large mass. Would you go for some additional immunostains for further classification apart from the stains that I shared with you? Would you go further with molecular testing and FISH? And finally, would you proceed for NGS depending upon the resources that you have?
So we have for answer number 1, 8%, no answer for 2 and 3, for molecular testing and FISH 23%, and for next generation sequencing 69%. So
I agree, that's the choice one would go for, but when we look at a case like this, it comes to us with a large size tumor and we have the sort of turnaround time of 2 weeks for NGS. We want to see something which can be a little quicker that we can try with, but of course, NGS would be the best way to go all out in the ideal situation. But depending upon the resources, I think nobody would be incorrect, and we will be using different ways of sort of classifying this tumor, which is important. So before I proceed to this question, I'll sort of take you towards the category of the undifferentiated small round cell sarcomas of bone and soft tissue that have been very well illustrated in the recent WHO 5th edition. And you can see this chapter is in between the soft tissues and the bone tumors, because you can see these tumors coming in both bone and soft tissue sites. So the first type is the Ewing sarcoma sound, which is placed in this particular category, including the new kid on the block, adamantinum-like Ewing sarcoma. Genetically defined, you have these tumors with the gene that is the FET or the DET gene fusing with the EDS family of transcription factors. That's how we define Ewing sarcomas. If there is a WSR rearrangement with this FET or DET gene and the fusion partner is a non-EDS family of transcription factors, so that could be a round cell sarcoma of the second type, and that includes the EWSR and FAT-C2 or the EWSR FAT-Z1 positive tumors. Then we have the CIC, the chip rearranged sarcomas, which include the fusion with the ChIP-DUX4 or the NUT fusion genes. And then we have the sarcomas with the BCOR genetic alterations, including the BCOR CCNB3, BCOR I2D, or BCOR mammal positive tumors. So even though we know Ewing sarcomas are round cell tumors, we have a spectrum with which Ewing sarcoma can show itself. We used to call more rosettes as PNET. We don't use the word PNET anymore. The Ewing's-like is also not acceptable in the present classification because we have these defined genetically. So we can see atypia when you see most prominent nuclei in otherwise is Ewing sarcomas. The epithelial differentiation that can be seen in about 5 to 32% cases. We've seen in 23% cases in our experience, including the cases of adamantinum-like Ewing sarcomas that show epithelial differentiation. When you see a sclerosing pattern, a differential becomes of a desmoplastic small round cell tumor. Seeing clear cells is not uncommon in Ewing sarcomas. We had an occasional case of Ewing sarcoma being referred as a vascular tumor because there were a lot of areas of hemorrhage. And if we see spindle cells in round cell tumor in a possibility of Ewing sarcoma, one needs to go tangentially towards thought of perhaps we might be dealing with a BCOR rearranged tumor. So that's a new kid on the block, the adamantinum-like Ewing sarcoma that has appeared in the recent WHO classification in the chapter of Ewing sarcoma. And these were initially described by Julia Bridge in the bones, in the long bones. And of late, it's been very well identified and described in the head neck location, including sites like salivary glands, the thyroid, and the neck muscles. In terms of our experience, out of 34 cases of Ewing sarcoma that we had with epithelial differentiation, we were able to cherry pick 6 cases showing these adamantinum-like features. We had a very unusual case of adamantinum-like Ewing sarcoma in the calcaneum, showing this very prominent squamous differentiation, looking like a squamous carcinoma, actually. And then my colleague in head neck, we pulled out additional 6 cases of Ewing sarcoma, which is the most common location for these particular new variants. So that's the case of a adamantinum-like Ewing sarcoma we had in the calcaneum. You can see this very prominent squamous differentiation with these round basaloid-looking cells. And this was positive for the EWSR gene rearrangement. You can see the red-green split signals, 22q12 gene. So that's the essential criterion for substantiating this diagnosis. This was also positive for the NKX 2.2, but it didn't respond very well to chemotherapy. We had about 5% response and 95% residual tumor. So these might not respond as well the classic Ewing sarcoma does. The other tumors that I just alluded to include the BCOR CCNB3 positive tumors, I think we all know, described by the French sarcoma group by Gaël Piagon, and the ChIP-DUX4 positive tumors very well described by Dr. Katia Specht and Dr. Christina Antonescu, who've done this phenomenal work on these tumors. In terms of our experience, we had about 12 cases of these, including the 5 BCOR CCNB3 positive tumors and the 7 ChIP-DUX4 positive out of 32 cases that we triaged these for molecular testing, which is the essential criterion to substantiate this diagnosis. Then I pulled out in 12 cases with my colleague from Turkey, Dr. Kemal, and we had these 12 cases of BCOR CCNB3 positive tumors. These are the ultra rare tumors. And just off late, we had additional 5 cases of the ChIP-DUX4 positive tumors. And that's the recent publication hot off the press by it's a multi-institutional study. I think we all are aware of this excellent paper by Dr. Emanuela Palmerini, who's leading this paper with all the other investigators. And they've identified 88 out of 148 cases of the CIC rearranged tumors. And then the others include the uncommon, the BCOR CCNB3 positive tumors. So ChIP rearranged tumors occur in more adult patients in contrast to the BCOR CCNB3 positive tumors, which are mostly seen in bones in contrast to the CIC or the ChIP that are seen mostly in soft tissues, and they're not sensitive to the usual chemotherapy for the Ewing sarcoma. Now, this was the case that we came across, which was initially diagnosed with three possibilities of osteosarcoma, small cell type, synovial sarcoma, and Ewing sarcoma. So the patient was treated on the lines of osteosarcoma, considering that this was radiologically looking and there were small round cells. But if you see carefully for the pathology perspective, we have these oval to spindle shaped cells with these delicate blood vessels, and this bluish stroma is kind of a good clue towards consideration of a possibility of a BCOR positive tumor, which this was the BCOR CCNB3 positive sarcoma. So this patient, tumor did respond to chemotherapy in terms of 73%, but that's not a good response with this residual tumor. And unusually, there was a bone formation in the post-chemotherapy resected specimen. That is, again, a very rare phenomenon for a BCOR CCNB3 positive tumor that we had. This was a case of a 35-year-old lady who had this 2.6 centimeter sized tumor in her thigh that was resected. And morphologically, it shows this very round to epithelioid to rhabdoid cells. And that's the time when we think of the usual suspects like rhabdomyosarcoma or the rhabdoid tumor that were excluded with immunochemical markers like INI1 retained and a negative expression of desmin, myogen, and myoT1. That's the time one needs to think further towards triaging with markers like WT1 that we did. And it's noteworthy to see that this tumor also is showing this membranous MYC2 expression that we see in Ewing sarcoma. Finally, this was a CIC ChIP-DUX4 positive type 2. You can see the fusion band at 230 base pairs confirming a diagnosis of the ChIP-DUX4 positive sarcoma in this particular case. So coming back to the present case, how we went further, we did FISH, and we, because it's a one-day test, because if you go all out for the NGS, which is the ITL, it takes like 2 weeks with an additional cost. So this showed the rearrangement. You see the EWSR split signals, and apart from these split signals, you see a very typical multiple red signal. So it's kind of the co-amplification that we're seeing in this otherwise rearranged tumor. It didn't look morphologically Ewing sarcoma, and genetically also it was negative for the fusion, that is the EWSR FLI1 and the ERT in this particular case. So with this amplification of this rearranged tumor with this morphology, I started to think towards perhaps this could be an EWSR and FAT-C2 positive tumor. And that's a nice paper by Akiko Yoshida from Japan, who shown that, NKX3.1, a marker that we use for prostate carcinomas, can also be utilized to think towards the possibility of the EWSR and FAT positive tumor. And this tumor was positive with this marker. So my impression was that this is not Ewing sarcoma, kind of ruled out an myoepithelial tumor and the extraskeletal myxoid chondrosarcoma, the usual suspects. And I thought perhaps this is most likely going to be an EWSR and FAT-C2 positive sarcoma. So in terms of the metastatic workup, the patient unfortunately had multiple nodular opacities, and these were kept avid with the SUV of 6.2. The patient was initiated on the adjuvant chemotherapy with VAC regime with a palliative intent followed by radiation therapy. And then in the meantime, I sent this case for the NGS to my good friend, colleague from Bordeaux, France, François Loire. And this was positive for the EWSR and FAT-C2 gene tumor. So these tumors are very rare. They're seen most frequently in males, more commonly in bones and soft tissues described in either locations, and they don't respond very well to chemotherapy. Unfortunately, our patient had these multiple, opacities. You can see in the lung filled almost with these metastatic lesions, and post 3 cycles of chemotherapy, he died of the disease. So that's the literature. This is matching literature about these rare tumors, initially described by Carlizo Hai in terms of another variant of these round cell sarcomas defined genetically. And there's a nice paper by Dr. Beata Bodham. Happy she's there as the panelist with their 4 cases, and they had 1 case in the soft tissue like ours. Most of the cases were dealt with surgical resection, and there was a good follow-up of 8 months to 11 years, wherein none of the patients died actually, and these were dealt mostly with resection, including NACT offered in 1 case. So we couldn't have this resection because the patient had multiple metastases during the metastatic work. I mean, they don't respond very well to chemotherapy as Ewing sarcoma does, and that's the importance of identifying these tumors. So let's see another part of the literature you can see in terms of the 6 and 4 cases. And like, the other, the markers that are identified, there's a new marker called Egrican, which has been identified and described by to triage or perhaps consider for these tumors, and these tumors in their study showed consistent positivity for this aggrecan, that is a high molecular weight proteoglycan. And our case was also tested, it was positive for the aggrecan-3. With this, you can see it's important to identify these tumors because they don't respond to the usual chemotherapy that we offer Ewing sarcoma. But there's some possibilities because it's been seen on the genomic and the methylome profiling that these tumors don't align with Ewing sarcoma, so they don't respond as good. But there are possibilities because they show the possibilities of mTOR pathway. It's been seen in some studies. So this could be one low-hanging fruit or perhaps a therapeutic target one could try for cases that we unfortunately lost. And with this, I would like to wind my talk with some messages that undifferentiated small round cell sarcomas do display a wide clinical pathological spectrum. It's important to subclassify because you have certain chemosensitive tumors like the Ewings we all know, and the BCOR CCNB3 also, in contrast to the CHICTUX4, which are aggressive tumors, and the NFAT-C2 and the FAT-C1, they don't respond very well to chemotherapy. There's definitely a value addition for molecular techniques, and NGS is great to sort out these rare or the ultra-rare subtypes. We have certain immunostains which are helpful in certain settings to triage for molecular techniques, but that won't be a replacement. Like the new kid on the block would be aggrecan for the NFAT-C2 positive tumors, just like we've had the BCOR for the BCOR CCNB3 and the WT1 and the ETV1 for the JCRS4 positive tumors. So as much as these are rare and challenging to diagnose, there are possibilities or scope for newer therapies, especially for the aggressive subtypes, which like the NFAT-C2, which might not be sensitive to chemotherapy as Ewing sarcoma does. So thank you again very much for the opportunity, and I'll be happy to take questions.
Thank you, Dr. Rekhi, in very, very illustrative case as well, and very ultra rare, by the way, case. And my first question is, this case emerged from the bone or in soft tissue?
So this was actually a soft tissue mass because we could see, unfortunately, we didn't have the MRI, but the X-ray didn't show the bone was characteristically spared. Even if there was a marginal involvement of the bone, the epicenter of the tumor was essentially in the soft tissue. These tumors are, in frequency more common in the bones, but our case was primarily a soft tissue mass.
Okay, because yeah, I have treated a couple of adamantioma in primary of the bone, but no in soft tissue, which is, in addition, is rarer, is more uncommon. Okay, nice. So we can open the time for questions and comments from the audience and panelists as well. Can we share? Okay, nice.
Thomas. Yes, thank you very much for this very interesting case. My question is, the round cell sarcomas are very interesting. And do you prefer fish because sometimes it's faster, and then NGS, or first NGS, or how to handle this situation?
I think that's a great question. So ideally, NGS will take care because it's high throughput sequencing. You have a choice for several, which you can. But there's a turnaround time. We are at a referral center. The patients are already, we saw the case unfortunately presented with multiple lung metastasis. So we need something which can be quicker and maybe less cost. And FISH comes good handy to triage such cases. So that's how we proceeded in this particular case. So ideally, it will be NGS if the cost and the time can be handled. But if there is a referred case, we're looking for something relatively faster. So FISH is good to triage such cases. I think so, and that's what we do.
Thank you very much.
Thank you.
Okay, I don't know if from the audience, anybody has experience with any systemic treatment, because I have just experience with pathopanic with anti-PD1, sorry, PDGFR alpha receptor, and I achieved some stabilizations And actually, there are some very few case report publications around that. I don't know if you have, Rekhi, or in your department, experience with inhibitors of PDGFR alpha.
So in these undifferentiated round cell sarcomas, the genetically defined in these cases?
Yeah, in adamantium. Yeah.
You're saying including the adamantinum, like Ewing sarcomas, right? Okay.
Yeah.
So the vast majority of such cases, including our experience, have been dealt with the chemotherapies available for the Ewing sarcoma protocol, that is the EFT 2001 that we have at our center. So that's, and I think even in I think the grade school study by Dr. Palmerini, most of the cases were managed, in terms of the chemotherapy with the Ewing's. We had some cases which were dealt with the osteosarcoma protocol, the one that I showed, because the initial thought was perhaps that could be a small cell osteosarcoma, and radiologically it did mimic an osteosarcoma. So these are the most common therapies, but I wish my oncology colleague was there to add towards your, I think, very good query. So I'd be very happy to know from the oncologists here, because we really look for, what could be the therapies towards, especially the chemo insensitive or the chemo refractory subset of these round cell sarcoma. That's been my off late area of interest. But thank you very much for your very, very important and valuable, I think, experience on this. Dr. Martin.
Maybe Scott or Alessandro has a comment. Do you have any experience?
We've also used TKIs with marginal benefit as expressed already. And unfortunately, this is a field that we have such rare cases. We're just going to have to figure out not to treat them as Ewings and try some other combinations as we go forward. But we're not very successful.
And I think this is a classical example of a histology type which is really ultra rare and a call for collaboration on a global scale. So I think we should try to put together all the cases we have in the localized and metastatic setting and see what the response to treatment look like. Because I don't think there will be any other way to understand more or to learn more in tumors like this than collaborating on a global scale. So I think this is a classical example, wonderful example of some super rare histology that really need us to work together.
That's a good point. Yeah.
And I think it could be easily, that at this year's CTOS, there is a section of Ewing and Ewing-like sarcoma. And this could be easily brought up even if by presenting a case report or a small series of this. The deadline is Monday, but I think that would be a nice opportunity to discuss this.
Yeah, I think that's a great suggestion. I completely agree that it's has a great scope for collaborative studies, and I think even Dr. Palmerini's study is a great collaboration with the large number of cases that we've published. So I completely agree, Dr. Bronchi, with your very, very great suggestion. Thank you.
So nice. I think we have to move on the last presentation, but not least.
Good morning or good afternoon. It depends where you are now. Thank you very much for the invitation. The idea is to present a case about a patient, a young patient, 5 years old, male, that he complains about lower leg pain with some complaint while he was doing activity and sport and running all around the houses. No symptoms of infection. And these are this case is from 2011. So these are the initial X-rays and MRI. Or probably we all can see a lesion in the distal tibia that affects above the growing physis in the X-ray and in the MRI. I don't know if someone from the panel want to try to give a possible diagnosis or an initial diagnosis. I don't know if someone wants to be part of the discussion and start answering. If not, we can go. We had some questions already programmed for the audience, but okay. The patient was initially treated in another center where they did a open biopsy, a surgical biopsy, and they confirmed the diagnosis of a Ewing sarcoma. So we are dealing with a small patient, 5 years old, with a aggressive sarcoma of the distal tibia, Ewing sarcoma. And here we arrive to the first question for all the panel and the audience. These are the X-rays and the MRI. The patient had small nodules, unspecific nodules below 3 millimeters in the lung. So what is the idea of how do you want to proceed after this diagnosis and this scenario in these patients?
It's for the pre-OP neoadjuvant chemotherapy, 53%. It's for combination 5% with combination 1 and 2, and for combination 1 and 3, it's 42%.
Okay.
Nothing for radiotherapy and for surgery.
So in the end, 92% chemotherapy in neoadjuvant setting and then surgery. Just joining the two options.
I don't know if someone from the panel has another consideration, but let me go on. Okay, so we go ahead with the chemotherapy, pre-op chemotherapy or neoadjuvant chemotherapy. This is how the tumor reacts to the chemotherapy. This is the post chemotherapy MRI. We use the Ewing protocol, and now we are in this scenario after the pre-op or neoadjuvant chemotherapy, and we will go ahead with surgery. So I will let all the audience to vote, and then I would like to hear or listen to any opinion from the panel, if what will be their options after that response of chemotherapy in this patient. 5 years old, distal tibia.
It's 100% limb salvage surgery.
So Alessandro, or Dr. Alexandro, you said amputation, or that was would be your first option in this case?
Well, not really, but I mean, I think you should always consider amputation here as an alternative because it's an easy process. It depends how fast you need the patient to recover, and on the long run, it's not. I mean, you should not take it for granted that the conservative procedure will end up in a better function.
Yes, I agree that amputation is always a very good option for this type of aggressive sarcoma in the distal tibia. Definitely,
distal
even
tibia
more in
and
a
foot,
very
I mean,
young...
it's really reconstruction. Functionally wise, I mean, it's at the end of the day has a lot of
Great, Andre, you have raised your hand. Andre Baptista.
Hi. Yeah. Do you take into consideration the response for the chemo before
you mean for
deciding what kind of surgery do you perform? Do you take? Excuse me. Yeah, just a question. You taking how do you measure the chemo response? Would you use PET-CT, for instance?
We always consider the chemo response. We don't use in general PET-CT. This case is from 2011. We usually try to see a reduction of the soft tissue mass in general in Ewing sarcoma, or the extension of the lesion in the bone. But we definitely consider the response to chemo a crucial factor in order to indicate a limb salvage surgery or amputation. Francis Lee?
Yes, excellent presentation. I know all of you are so fantastic surgeons, Jose, Luis, and Romano. You guys are so technically superb. I think you may have done, or you may do, physeal saving surgery using proximal humerus allograft of a small lady, so they can match the metaphyseal bone. Or you could have done probably vascularized procedure in conjunction with the allograft. That's what I'm suspecting, but I can be very wrong.
Okay, so according to what Francis Lee recently said, let's imagine that we decide to do a limb salvage surgery, which will be the best reconstruction, or which will be the reconstruction that the audience and the panel would choose. Then the second option is non or vascular fibula, any of those, or biological autologous reconstruction.
Can I, Nacho?
Hi, Shintaro, how are you?
Yeah, hi. Very fine. Thank you. Thank you for presentation. So in this case, so I try to do our best to preserve the leg for a young lady, and in this case, the EP, I should stop the answer the question, or after the finish the voting. Oh yeah,
we have 7% for EPR, non-vascular fibula 40%, and allograft 53%.
Yeah. So in this area, EPR is a little bit difficult option, and I will do the autograft by using the liquid nitrogen with the non-vascular fibula implantation inside the medulla.
Yes, I agree with Shintaro. That would be a very good option. Let's show what we had done. So you all know our experience mainly doing allograft, but the first thing we planned was to try to do a growing physis preservation. So we tried to do a virtual planning and then a navigation and resection of the tumor with free margins just above the growing physis. This is the moment that we are using the navigation and trying to do the section of the distal part. And this is the navigation where we are planning to do our osteotomy, the guide by navigation. The big problem after doing the resection, this is the defects, the bone defect after the resection, probably was to imagine or to try how to do a solid reconstruction. So what we do also is we navigate the allograft. So we choose the better allograft from our virtual bone bank and try to reproduce the exact reconstruction with navigation. And we always consider to do an allograft a bit longer, 1 centimeter, that in order to reproduce what the saw consumed from the bone. So we always plan an allograft a bit longer. This is the allograft we plan. And then the difficulty or the big deal was how to fix or try to stabilize that allograft and reconstruction, mainly in the distal part, because we have very few bone. So we plan and we navigate these two screws, the distal screw with the anterior plate, and that was the final result, trying to preserve the growing physis and trying to give a good stabilization for the allograft. We all know and we all know about allograft and young child, that is a very good option in general for them for consolidation. We don't expect in general non-unions in very young guys, although we're using an allograft. This was the result of the resection. Free margins, luckily as we plan in the pre-op virtual planning, with 99% of necrosis. 99% of necrosis. So now I would like to see the answer of the audience and from the panel also, what you will do after this result of 99% of necrosis in a uveal sarcoma of a young child. How you will continue or will you proceed?
Okay, while waiting, have you ever used the cannibal destruction technique at the distal tibia?
We have no experience doing the destruction. I know obviously in Spain they are very famous and very keen on doing that. We have not much experience doing that, and in general we have not practiced that in the distal tibia. I read a question recently from Rob Greimer. I say hi. Robert was one of my mentors in UK, so thank you very much for the question. Saying that he has done an EPR in a very young child, a child of this age, that was still working well. So EPR is another option I realized from this type of reconstruction. Miguel Murcia asked in the chat also which margin it was less than 1 centimeter, but free margin.
So I will give you now the answers. We have POP chemotherapy, 70%, POP radiotherapy, 5%, oncological control, 10%, and the combination of 1 and 2, 15%.
Okay, great. I don't know if Jay Gunder is available or he's connected, but if he's listen or he could answer, I would like to see his opinion about radiotherapy in this case. I don't know, because he was ready to go to surgery probably, or any other member from the panel. Radiotherapy is a good option in this young child with an technically open physis.
I think if you give radiotherapy, you will destroy both the growth plate as well as you will compromise the healing of the graft that one has put in. So I think if the plan is to reconstruct with bone, it would only be if you're planning not to give radiation. And with good margins and a good response to chemotherapy and tumor-free margins, I think we can just cover with chemotherapy without any radiation.
Okay. I would also be reluctant to use radiation in this situation. Maybe Gabi wants to tune in.
Hi, it's Jay. Can you hear me?
Go ahead, Jay.
Oh, hi. Yeah, that's a really great case. And you know, I think doing limb salvage, obviously with a good response like that, and joint sparing is really good. I was just I was also going to say, you know, the distraction technique probably would be great for a case like this because the physis is, you know, small. But my question was going to be, I like your reconstruction, but do you not have any concerns about putting pins, putting 2 screws through the growth plate, in terms of you're trying to maintain the growth plate, but then you put 2 screws through the growth plate because of your plate. Could you have just put, you know, some K-wires temporarily, or is there any other way to fix the graft that would have less chance of interfering with the subsequent growth of the physis? Or do you have experience that putting those screws across is okay?
Yeah, the idea, and I will try to continue a bit to answer Jay's question, is the idea was to put the screw in the first month, and as I said previously, when very young child, we used to see obvious in distal osteotomies in general, very good consolidation, not problem on non-union. And when we considered that the allograft was healed or trying to heal, we decided to take out the distal screw, and they were removed approximately at the 8 months post-op. And this is the situation. Definitely, we can use key wires to do the fixation, but we always try to do the first fixation the more rigid we can. So we consider that.
No, I agree. Yeah.
Was probably the best.
So you left those screws for eight months?
Around 8 months, yes, when we consider that the distal osteotomy was already healed.
I see. And do you have any, is there any follow-up? Like, have you seen that the physis is actually growing after that, or does the screws disrupt it, or no?
This is the follow-up. So
Yeah.
8 months, 16, 17 months, and 20 months.
Wow,
and
that's
definitely
great.
the growing physis was working, was alive.
Sure.
And we can see it. But this is the situation. Look, nearly two years after the initial surgery. This is the reconstruction, the function that the guy has.
Wow.
Definitely, there was probably an extra valgus in that ankle that we can easily see in the X-ray. Probably much more force in some part of the allograft, something that a bit worried us. And let's continue. So he was now 7 years old, around 2 years after the initial surgery, running all around the houses. He suffered from pain and he complained from pain. We took an X-ray. He was not from our city, so they did the first X-ray outside our hospital, outside our city. They put a cast, and definitely they diagnosed a fracture. Something that could happen. It's a complication that sometimes we had to deal with when we do allograft reconstructions. And so in this situation, and probably any of the surgeons from the panel, what you will do? You would do. Andre?
Well, this is a well-known complication for allografts, right? And it's easy to say now, of course, but retrospectively thinking, do you think an anatomic distal tibial plate would be better for this case at the first surgery? And what I would do in this case now is probably put a vascularized fibula with an anatomical distal tibial plate fixation. That would be my recommendation.
Okay, and the distal tibial plate above or below the groin physis?
Above.
Above, okay. So vascular fibula plus changing the osteosynthesis, changing the plate, keeping the allograft. Shay, which is your opinion?
Yeah, so we've had some cases in kids where they have an allograft fracture, and if they have a good soft tissue envelope, we've actually had cases where we've just used iliac crest graft and extended the plate, and we've been able to get the allograft to heal. But that's not particular. I don't know that you can count on that as always working, because obviously the allografts, if they fracture, they're not meant to heal, and although sometimes that can happen, it's not routine. You could treat this like a metastatic type lesion. You could fill that with cement, fill the whole allograft with cement, and then reduce it and extend your plate. When we, in our intercalary allograft experience, like the Toronto stuff we've published, we always fill our intercalary allografts with some antibiotic cement, and then we don't put cement right to the end of the intercalary allograft, but almost to the end. And the one thing about that is that we almost never have any fractures. So filling the graft with cement and then having very few screws through the graft makes the graft work really, really well in terms of the long term, and almost avoids this problem of fractures. But that's in the beginning. And going back and trying to put this together with cement now with a plate and with bone graft, it might work, but you don't know if it's going to work in the long term. I think for a kid who's now probably a couple of years out, has had a good response, who's probably cured, it might be better to just add a vascularized fibula and either use the vascularized fibula alone or take out this graft and do a new graft with a vascularized fibula. That might be the best way to provide really good healing in the long term.
Great. Any other comment from the panel? Any other?
Yes, can I make one comment?
Yes, Francis.
Again, I'm always a little bit outside the box and crazy. We see progressive valgus. So I think we may do distal tibial fibula syndesmosis by putting screw through the fibula. And you can use that proximal segment of the fibula as a rollover graft. That means it's a kind of regional vascularized fibula graft that will fit into the defect or bypass the fracture site. I mean, technically it's doable and conceivable, but I don't think technically I'm not good enough, but you can do it, I think.
Great. So trying to be on time. So we decide to do the first option that say mentioned. So we change the plate. We try to put a longer plate and stronger plate, and we use a bone from the iliac crest from the patients, trying and being confident that he's a very young patient with a lot of biological potential, and trying to see if that allograft could heal. We have fortunately good results in this patient. This is the follow-up in 2016, 2017. This is the results after solving the fracture of the allograft. And as probably Francis Lee recently said, we try to improve the alignment of the ankle, trying to improve that valgus, residual valgus, that probably was one of the causes of the fracture, the mechanical wrong forces that were working in that ankle. This is the situation in 2018, 7 years above the line, no systemic disease, no metastasis. This is the function he has with a little discrepancy in 2018. It was around 1.5 centimeters, but very good option. He was practicing sports, not complaining about pain. And the final results, he's now 17 years old. He's considered, let's say, cured or without any more follow-up in terms of oncology, 10 years above the line, 11 years. He has a length discrepancy residual of 2.1 centimeter that he generates not much problems in his daily life. He used just a supplementary in his shoes or sneakers, and he is now practicing football and tennis, although we try to avoid contact sports in patients that are treated with allograft. It's not so easy to explain that to these young adolescents or patients. So as a final message, distal tibial reconstruction is always a challenging anatomic area and difficult to reconstruct. Definitely amputation is a very good option. But if we could try to keep the limb is in our opinion, the first option. Allograft could be an option for young patients, mainly when we could preserve the joint. In general, not only allograft, biological reconstruction. We have the message from Rob Greimer that he has a very good result with a patient with an EPR, but we consider in general biological reconstruction in this age. And if we have a tibial allograft fracture, we had seen that could be solved with a new osteosynthesis, stronger and iliac crest bone, mainly in young patients. That was published. We have seen that better results in the tibia, not in the femur, probably because of the mechanical forces of each bone. But in the tibia, we can rescue or we can save a fracture with this not so aggressive treatment with iliac crest bone graft and a new plate. So thank you very much. And that was the complete case.
Nice. Jose, very nice. There are some questions left from the audience. Dr. Barry, is the limb circumference measurement a reliable indicator of response to neoadjuvant chemotherapy? I would say it's not very reliable.
Yeah, I think it's difficult to say. Obviously, we will be very happy if we could find an imaging method to determine which is the response to chemo to pre-op, doing the pre-op surgery. it's difficult to set that, but we in general consider that if the volume of the tumor is reduced, we in general consider that that is for us a good response in general. The big problem is the phases, but the margin, I think, it's an option. So we always try to give more than 1 centimeter in terms of margins. This was a special situation or a special case, but in general, we always try to give at least 1 centimeter of free bone, safe bone. And do you think it's an option to manage the allofracture bone with substitutes or MVP? What we have seen is that the best option to try to rescue or to solve allograft fracture is try to use the iliac crest bone graft. Probably is that the best option more than substitutes or MVP. Andre, you
have time for a last question?
Yes. Yes, please.
What would you do if the tumor touched the physis? What would be your choice?
If the physis was affected, you mean?
Yes, if the tumor reached the physis, what would you choose?
Probably if it's a distal tibia, obviously amputation is always an option, but another alternative, this was a very young child, but probably in a bit bigger guy, we will choose to do an allograft arthrodesis. And then we try to do elongation or destruction of the bone above the proximal osteotomy when he gets bigger.
Not osteoarticular.
No, we have only few cases of distal tibia osteoarticular allograft, and really we don't have very good options, very good results. So probably would be an arthrodesis of the ankle.
Thank you.
Rob Reimer has another question here that says it had been poor response to chemotherapy or border margins. Would you offer radiotherapy or immediate amputation? If I have probably positive margins, I will offer an amputation. If it has bad response to chemotherapy, it's a very difficult answer, but because probably I don't know if he will have much more benefit from an amputation instead of a limb salvage surgery in terms of survival. So I think it's difficult. And definitely, if I have a marginal margin, I will not give radiotherapy, and I will try to control him very closely to see local recurrence and then amputation.
Yeah, with a bad pathological response, I will offer high dose chemotherapy in the adjuvant setting, irrespective the local treatment. I mean, this is a systemic disease as well. So I think amputation would not increase the probability of cure in the context of a lower than desirable pathological response. And we will offer high dose chemotherapy because we have a randomized trial demonstrating this benefit. So there is another last question, maybe, Jose?
Yes, recycling distal tibia with ankle arthrodesis and fixation as an option, I think is a very good option. You will sacrifice the distal physis of the tibia, but it's not the most important physis in terms of the lower limb. So I think it's an option. We have done some arthrodesis, not with recycling distal tibia with allograft, but then you have to know that probably you have to solve the length limb discrepancy that this patient will have if he or she survives.
Yeah, we have some patients with ankle arthrodesis like you with allograft arthrodesis of the ankle, and they do okay. They're not great. They're not as good as they're probably not as good as any other joint reconstruction, but they're probably reasonable. I think for a young patient who's very active and wants a very active life, an amputation with an artificial limb is probably way better. And for maybe an adult or somebody who's more sedentary or active sports or a very active lifestyle is not their most important consideration, saving their leg in an allograft arthrodesis is okay, but it's not as good as most other joint reconstructions. So patients sort of have to know that it's doable, but not as good at all.
Yes, in our series of distal arthrodesis of the distal tibia or the ankle, our number of complications is much higher than other anatomical area, and I agree with Jay that the results are not great. So
Yeah.
it's a bit controversial.
Well, most of the time there's a big mass and there's a lot of soft tissue reconstruction, and then they need a free flap, and then they're immobilized for ages to get it to heal, and then the result is it's nothing like an ankle arthrodesis in a regular person with arthritis, and it's a very big operation in a very small area. It's just not that great, but it's a reasonable option, but it has to be for the right patient and probably not great for a young kid.
Yes, I agree completely, and definitely amputation continue below knee. Amputation continue being probably the gold standard treatment for aggressive sarcoma of the distal tibia.
So thank you very much, all of the presenters, all of the panelists, all of the attendees, because the high interactions. And this has been a very, very enriching meeting. And I think, Bruno, you can say the last words in this meeting.
Well, thanks so much. As you said, it was a pleasure that you all again took the time and to discuss these difficult cases. I think we all can learn, and I hope we can meet after the summer break again in August when we talk about hypofractionation in radiation therapy, hosted by Andrew Bishop from MD Anderson.
Very much.
Thank you.
Bye-bye.
Thank you. Bye-bye.
Bye-bye.
See you.